Hello, my name is Richard Brandt, and my literature review is on the de-escalation of antimicrobial therapy in patients diagnosed with sepsis or septic shock. My PICO question is as follows. In septic adult ICU patients, is the early use of multiple broad-spectrum antibiotics more effective than delaying the use of a single narrow-spectrum antibiotic in treating severe sepsis, and how does de-escalation play a role in the antibiotic choices in order for the patient to survive septicemia? The population would be obviously the adult ICU patients who have been diagnosed with sepsis. My intervention is broad-spectrum antibiotics compared to the de-escalation of the antibiotic therapy versus the use of narrow-spectrum antibiotic. And the outcome would obviously be septic survival. Now, de-escalation is when you are changing from a one type of broad-spectrum antibiotic to a narrow-spectrum antibiotic, or you are changing the dosing regimen or the therapy regimen, basically going from a, say, Q every 8 hours versus every 10 hours versus every 24-hour treatment of antibiotic. Now, de-escalation is currently the standard of practice for septic and septic shock patients. And basically, they send off the blood cultures, all the cultures that they've performed, get a microbiology report after 72 hours, and then they will de-escalate the type of antibiotics. According to the primary research that I found, majority of the de-escalation research is done in a retrospective observational study, and they have shown that this would be a standard of practice using de-escalation in the treatment of septic and septic shock patients. However, I found a research study that goes really kind of contradictory to what the observational studies have shown. It is a multi-center, non-blinded, randomized and non-inferiority trial that basically took patients once their microbiology has resulted and either randomized their de-escalation versus continuation of the empiric formula. And what they showed was that there was no change in morbidity, mortality, ICU stay, hospital stay, length on a ventilator. Everything actually stayed the same except for patients who were de-escalated. They actually ended up developing more of a superinfection than those who remained on the continuous empiric formula. It's a very interesting study. There will be more details in my literature review. However, that should give you the information you need on that. The conclusion of my literature review is that de-escalating the antimicrobial therapy is very important in treating sepsis and septic shock. However, there needs to be more randomized control trials. There needs to be more studies from the front end instead of looking at everything retrospectively. We need to be looking more at what does the empiric formula have that the de-escalated therapy not have? What's going on? Why are people who are de-escalated developing more superinfections? Why are those who are still on the empiric formula not developing superinfections? Those kinds of things. We need to be looking at those kinds of things, finding answers as to why this specific study is showing what it shows. We also need to make the assumption that maybe de-escalation is not a favorable treatment plan for all patients. We want to see if maybe somebody may not be a good candidate for de-escalation. We need to be looking at treatment of bacteria and septic and septic shock in a more individualized basis. And these are my references. Thank you.